than Dr. Margaret Obono. Dr. Margaret Obono is the Director of Pharmacy Department, National Orthopedic Hospital, Igbobi, Lagos. She is a fellow of PSN. She has served in many PSN committees, has been the National Treasurer of PSN. She has also served a number of leadership positions, which include the Secretary of the Faculty of Hospital Pharmacy, West Africa Postgraduate College of Pharmacists. She is also Secretary, Committee of the Heads of Pharmacy in Federal Health Institutions. She is a one-time Chairman, Association of Lady Pharmacists, Lagos State, and lots more. She is actively involved in the training of Girl Child, which was adopted when it was her tenure as a chairman of ALPS. Again, I welcome Dr. Margaret Obono. Ma, you are highly welcome in our midst.
Thank you very much. Thank you, Chioma.
Thank you so much, Ma. We are hoping to grab so much from your wealth of knowledge today, and we invite you to proceed with your presentation. Thank you so much, Ma.
Thank you. I'm trying to share my screen. Yes, good evening. I don't know if you can see my screen now.
Yes, you can see it.
Okay. Thank you very much. Good evening, everyone. Good evening, colleagues, senior, younger, professional colleagues. Good evening and welcome. Thank you, Sipan, for this opportunity that you have given me. Today, we are talking about benchmarking tool for pharmaceutical care and clinical pharmacy activities. And I'll be using this outline, take some definitions. Why do we need to benchmark our activities? What are the tools available? How do we apply or implement these tools? I'll take conclusion and references. So benchmarking is a tool for identifying and reducing variations in practices and resulting outcomes. Benchmarking does not only apply to pharmacy practice. Benchmarking could be done for so many other activities, as we will see as we go on. Benchmarking has been defined as a continuous process of measuring products, services, practices against an organization's toughest competitors. Usually, big organizations want to compete in the market with their competitors, and so they benchmark and compare themselves so as to improve their services or overtake their competitors. What is clinical pharmacy? It is a health science discipline in which pharmacists provide patient care that optimizes medication therapy and promotes health, wellness, disease prevention, and embraces the philosophy of pharmaceutical care. Pharmaceutical care, like we all know, is the responsible provision of drug therapy for the purpose of achieving definite and sustainable outcomes that improve a patient's quality of life. Pharmaceutical care, we know, is patient-centered. Studies have also shown that clinical pharmacy activities of pharmacists, they have been documented to meaningfully impact on patient outcomes such as improving readmission figures and mortality, reducing them, and of course drastically reducing the overall cost of healthcare. Now, pharmaceutical care is meant to improve the quality of life of a patient. It's supposed to give quality healthcare. And quality healthcare can be defined as the degree to which health services for individuals or populations increase the likelihood of the desired outcomes that we want.
Dr. Margaret,
Yes, please.
we have poor audio quality from your end. Probably there is something else making some noise.
Noise.
Yes.
Wow.
We would be grateful if the noise is reduced. That way our members can benefit maximally. Thank you very much, ma'am.
Thank you. Let's see, is it a change in position or something that
Maybe
will
the
help
fan,
us?
is the fan close by?
It's not on. Actually, yeah, there are gens that are on
Oh,
some distance away.
I just remembered. I'm
Uh-huh.
talking about Lagos.
Uh-huh.
Continue, ma'am.
So I'm so sorry, and I really don't have much control over them.
Yeah.
Wow.
Just
What do-
proceed now. We'll
Okay,
pay attention.
okay. Sorry about that. All right. So yeah, so I'll continue by saying that benchmarking is not a one-time event. Like we said, it is measurement of our activities. It shouldn't be a one-time event. It should be a continuous process, because when you evaluate your service today, in another year, the best of today may be minimum standard for tomorrow. Because of advancement of science, we would have gone further than we are today. So it should be actually a continuous process, not a one-day thing. I brought in examples of companies like Toyota, which we all know that are very good companies, have made a mark in the market. These companies continuously benchmark so that they can stay above their peers. Toyota, Apple, Xerox, these are all companies that have used benchmarking to improve themselves. They actually measure themselves against the industry leaders. They compare their products, their services, their practices with others in their field and continuously try to stay on top. That's what we are talking about today, benchmarking. How can we improve our services and stay relevant and be valuable, improve our value? Why should we benchmark? I said that in the provision of our services, especially for health insurance, for private hospitals, even for public hospitals, health managers will usually want the best from their facilities, and they want return on their investment. So if they're employing pharmacists, clinical pharmacists, they want the best from them. So there must be minimum standards. They need the best possible services from the professionals, services that will improve patient care and patient satisfaction so that they continue to be in business. Health administrators will want to be able to justify pharmacy staffing. They will want, with minimum staffing, to be able to improve their expenditure and save costs. I gave an example of the study by McDaniel and Dijon, where they said that with an investment of $95,000 on clinical pharmacists, there was a resultant reduction in expenditure of over $300,000. So you can see that that's good investment on returns, and that was using benchmarking. There is currently no international consensus on the quality indicators of clinical pharmacy activities. There's no international consensus. So recently there was a presentation by pharmacist Silis Marine from Belgium during the just concluded European Association of Hospital Pharmacists virtual conference in March, where she made a presentation of the tools they use in Belgium for benchmarking activities of clinical pharmacists. And these are the tools we want to share. Now, how did they come about this? They made forms, they came up with forms which were distributed among clinical pharmacists from different hospitals to say activities, clinical pharmacy activities that have been demonstrated to significantly positively impact patient outcome. And they came up with over 50 specific activities, out of which they again went back using a five-point Likert scale to ask that these activities mentioned be prioritized. This Likert scale had from 1 to 5, with 1 being strongly disagree to 5 being strongly agree. And these clinical pharmacists, according to their years of experience, were made to choose out of the over 50 quality indicators or clinical pharmacy activities that have impacted the life of patients. And then they came up. Yes, please.
Another little modification. Click on slideshow, ma.
Okay.
Can you see it there on your screen? Dr. Ibrahim, please help out. Click on slideshow.
It is at the top of the slides. Top.
Top left or top
slideshow.
right?
Yes. Left. You see slideshow. Just move on, up, man, up.
Okay.
Up. Yes. Up. Then to your left. You see slideshow. Just slideshow. Just click on it. At the top. Okay. Go. Okay, man. Next. Okay. Then up here. Up. Yes. Up here. Up.
Further up, I can see videos.
Further up, man.
Further up. So
yes,
sorry.
Is this slideshow? Just a bit further up, just a little bit up.
On the tab menu, I think on the topmost tab menu, right?
Yes, it is written there, slideshow. Yeah. Just move the cursor a little bit up. Okay, sorry, ma.
Sorry. I'm seeing new share, chat, post share, remote control, more, probably more. Let me see more if I can get that. So sorry. Wow.
So for
I'm
Granny,
sorry.
I am also not seeing slideshow on her screen.
But I can see this one here. Oh.
Wow.
Why your cursor is just below it? Just move your cursor up a bit. Yes. No.
Could it be that?
No. Yeah, far away from. But maybe you should continue that way, ma.
Oh, I'm so sorry.
No, ma, it's not a challenge at all. It's just that slideshow makes it
Could have
easier
been
and
better.
bolder. Yes.
You can only come down. You can come down lower to lower. You can come at the bottom too. There's another one at the bottom. Yes, just come straight down. Okay. And then move to the left.
Left.
So yes, okay. Continue, ma. Continue. Yes, click on that. Click.
Oh, okay. Yes, I've seen something like that.
Just click on that.
Yes, I did.
Yes, just click on that side. That one. Okay. Click on it, ma. Yes, exactly, ma.
Okay.
Very okay.
It's better now.
Better, ma. Yes, better. Yeah.
Okay. Sorry about that. Okay.
Right on, ma. We're enjoying your presentation.
Okay. Sorry for the interruption. Yes, so I was saying with this procedure now, they came up with 10 quality indicators according to the relevance and ease of measurement of these indicators. And these were the selected indicators. You had medication history, medication reconciliation at admission, multidisciplinary meetings, that's pharmacist participation at multidisciplinary meetings, patient monitoring during hospitalization, patient education, discharge letters, providing information to the healthcare team, safety of patients, economic factors, and then general activities, which includes activities not directly on patient, but activities promoting good medication practices, like drafting of protocols, formularies, meetings, and so on. So these were the top 10 quality indicators to measure the clinical pharmacy activities. Focus on these were associated with evidence-based impact on clinically important outcomes, suitability for any kind of clinical pharmacy program, and readily availability or association with continuous performance of these clinical activities. I mean, these were the criteria with which they chose the 10 quality indicators. Now let's go into the quality indicators themselves. First was medication history. Medication history was measured as number of patients whose medication history was recorded within 24 hours of admission as compared to the number of patients admitted during that period. The next indicator is medication reconciliation at admission. Number of patients admitted for whom the pharmacist checked that all the stages of medication reconciliation have been performed within 24 hours of admission, and this is measured in comparison with the total number of new patients admitted during that period. The third one was participation of pharmacists in multidisciplinary meetings or activities. Number of times pharmacists participated in multidisciplinary activities, being medical rounds, nurses rounds, and so on. And that is measured as compared to the number of weeks that you're looking at. You could take 1 month, you could take a quarter, and then calculate the number of meetings that pharmacists participated in as compared to the number that actually took place. Number 4 was patient monitoring during hospitalization. Number of times that pharmaceutical records, total number of patients admitted, that is pharmaceutical records of patients as against the total number of patients admitted, or the number of interventions that pharmacists made and were accepted as against the total number of interventions within the healthcare. So if the pharmacists in the multidisciplinary rounds made interventions 30 times, how many of them were accepted? That is what we are measuring. Accepted and implemented. Patient education. The number of patients that have received therapeutic education from patients. There is another point that has to do with discharges. This one is not discharge, it's during hospitalization. For outpatients and for inpatients, number of patients that received therapeutic education from patients as compared to the total number of patients admitted. Then for discharge care, this measurement was number of patients who received written information about their medication on discharge from the hospital as compared to the total number of patients that were admitted during this period in review. It could also be a measurement of patients that received oral information on their medications from pharmacists. It could also be a measurement of the number of general physicians or practitioners who received written information on their patients, on the patient's medication from pharmacists, as compared to the total number of patients admitted during that period. The seventh quality indicator that we could use to measure our service is information provided to the healthcare team, like the drug information unit, number of drug inquiries that came in, number of responses that were made to those inquiries as compared to the number of weeks that you are measuring and looking at. Safety is the eighth selected quality indicator. Number of interventions accepted to prevent, to detect, to assess, to manage, and to report adverse reactions, documented adverse drug reactions, as compared to the total number of patients admitted. So this is the tool for benchmarking of safety of patients. The ninth one is economic factors. This has to do with the number of interventions accepted in one. Did you make an intervention to bring about cessation of medication, probably a wrong medication? If the pharmacist made such an intervention, was it accepted? Was there an intervention on dose reduction? Was there an intervention on formulary switch? Intervention on movement from intravenous medication to oral medication? Switches from branded products to less expensive generic products that are equally effective? or cessation of parenteral nutrition. We are aware that where there is cessation of parenteral nutrition, most times there is improvement in the quality of life of the patient. So these are all measurements that we can use in comparison with the interventions that were made. And then the 10th one is a general activity bordering on protocols, drafting of protocols, participation of pharmacists in DTC committees, drafting formularies, training of students, training of interns, and so many other things will fall into this group. So these are the quality indicators that we can use to measure our clinical pharmacy activities. And with these, we can say whether one particular health institution is doing better than the other health institution, or it could be a benchmark for comparison, such that every institution, 10 institutions are asked to submit these indicators and how it affects them. And with that, we can choose the hospital where clinical pharmacy activities are actually tops, or they are doing best. Like I said, benchmarking is for comparison, and that will of course help us measure our services, and we can now talk of improvement. Yes, I've talked about activities. The pharmacists that chose these quality indicators were concerned about meetings they attend, which are not directly related with patients' care, supervising students, and other activities that are encroaching into direct patient care. Now, if we are using these quality indicators, how do we implement them? So I say implementation of these quality indicators in benchmarking will help us identify our strengths, our weaknesses in services. It will help us implement pharmaceutical care where we are not implementing, or improve on that. It will help us compare practices between institutions. And remember, comparison of practices, we should also remember that you have specialist institutions, you have oncology, you have neonatal critical care. So usually comparison is among equals. Institutions, health facilities that are offering the same type of services. Benchmarking will help us exchange ideas within and between health facilities. It will help us assess and promote the quality of clinical pharmacy practices that are currently going on. And it will help us demonstrate the efficacy of pharmaceutical care and clinical pharmacy activities to health administrators, so that they are not just looking at us as these people that trade on drugs or are just there to count tablets. There are different types of benchmarking. There are actually 4: internal benchmarking, external benchmarking, benchmarking of performances, and benchmarking of practices. Internal benchmarking is where one assesses himself, or an institution as organization assesses himself. How have I performed over time? How was I 3 years ago, 5 years ago, and now? What is my performance like? Am I improving or not? External benchmarking, that is comparing between institutions with similar size and performing the same services. Now, I say drugs represent one of the largest supply expenses in hospital. So pharmacies and our activities cannot be ignored. We must make an impact. We cannot be relegated to the background. So we need to benchmark, we need to showcase our value, we can develop pharmacy workload monitoring systems that will analyze the impact of pharmacy services on patient outcomes, so that these things can be documented and used to make presentations to health administrators. I said, will it be difficult to ignore me as a professional? And this will be based on the service I render. If I am making as much impact as I should make with so much education I have received, will it be difficult for anyone to ignore me? I want us to think about that, because it is the value you bring to the system that will determine whether you can be ignored or not. I have this other quote that said, don't wait for others to define you. Define your value. You define your value yourself. Brand yourself. And that is what benchmarking will do for us if we take it up and decide to start benchmarking ourselves. Another one says, if your presence doesn't add value, will your absence make a difference when you're not there? When you're present, you must add value, because if you don't add value, when you're not available, you will not be missed. Implementation of benchmarking, there are softwares that can be used for benchmarking. And one of them I picked up is drug cost opportunity analytical software. This uses spotlight colors, red, yellow, green, to facilitate the analysis, such that when you're not doing well, it shows you the red card. If you're getting better, it shows you the yellow, and you're doing well, it shows you the green. Benchmarking of quality of our services and outcomes should not only be done based on the costs or income that we are generating. Activities like length of stay of patients in hospital, we can use that to measure the quality of service we are rendering. If we are reducing the length of stay of patients, and of course a reduction in the length of stay of patients will translate to a reduction in the total cost of healthcare given to these patients. There was another study that came up with quality indicators, and they called them clinical pharmacy key performance indicators. The study was done by Fernandez and his group, and they had 8 quality indicators. They are almost like the ones we have seen, so we just quickly run through. The first one is on discharge medication care, and he said the proportion of patients who received formal documented discharge medication reconciliation and resolution of identified medication discrepancies by a pharmacist. I just want to pause here and say medication reconciliation we are talking about. I'm sure we all know that when we need to do medication reconciliation, we soak the case, subjective, objective, analyze the data we have already gathered and work out a plan. So identified drug-related problems, you work out a plan of intervention and how to solve them. I just thought I should pause because I've been talking about medication reconciliation, because it comes up in many of these. Another key performance indicator is admission medication reconciliation and best pharmacy medication history. And this is talking about number or proportion of patients who received documented admission medication by a pharmacist within, and review and resolution of these identified discrepancies within a certain period. So they are almost like the ones we have seen. Interprofessional patient care rounds, how much of it did we participate in? Critical care activities, number or proportion of patients receiving professional comprehensive direct patient care by pharmacists, number of patients that are receiving patient counseling, patient education. These are all measures. So this group came up with 8 key performance indicators, unlike the other 10. These tools are available online that I think we can make use of. So, in conclusion, I want to say that we need to measure our activities. We need to come up with national benchmarking tools that will help us as clinical pharmacists say where we are. Are we doing well compared with global best practices? Are we adding value to our services, to the care we offer to patients? Benchmarking enables successful practices while helping us to identify and eliminate inefficient and costly practices. I also want to emphasize here that we can, by benchmarking, come up with consultancy fees for most of the services we are currently offering that are not being paid for, are not being quantified. We can use these tools as a basis to come up with our own national tools for benchmarking of both community pharmacy practices and hospital pharmacy practices. I have some references here. Thank you for listening.
Thank you very much. Thank you very much. Thank you very much, Dr. Margaret.
Thank
We
you.
appreciate you, and this presentation was wonderful. Thank you again.
Thank
Thank you
you.
very much. We are expected to watch a short clip.
Okay.
I don't know if Dr. Ibrahim is ready. Network is not too good over there. Dr. Ibrahim, are you ready with the video clip?
Should I stop sharing so that can come on?
Most likely, yes, ma'am. Okay, I just learned that the video clip will come in later. So, Dr. Margaret, you can stop sharing. I believe, can you hear me? I hope someone can hear me.
Yes.
Yes, we can hear you.
Okay, okay, thank God. So, while we wait for the video clip, we will quickly proceed to the question and answer. And I think I can see some hands raised. So, quickly unmute yourself and, okay, quickly unmute yourself and introduce yourself and ask your questions. I wish network is really poor this night, so please bear with me. Please, if you can hear me, if you can hear me and you raise your hand up, please proceed with your question.
Loma, the audio is very poor from your end.
Yes, it is. I know. I apologize. Aderonke. Aderonke's hand is raised. I can see that. Please, ma, unmute yourself and proceed with your question.
Good evening, ma'am. Good evening, everybody.
Good evening. You're welcome.
I hope I'm audible.
Yes, I can hear you, ma.
Okay, that was a wonderful presentation, Dr. Bono. Thank you very much. Now, in hospital settings, pharmacists are always short-staffed. We are never enough to be able
Yes,
to...
Dr. Bello. All right.
We are never enough. Can I continue?
Yes, you can.
We are never enough to render quality service. At times, I think this is deliberate. I think it's an attempt to prevent us showcasing our
Today we are going to
ability
discuss
or
pharmaceutical
professional
care. So what is
services.
pharmaceutical
Pharmacist
care and how
Aderonke,
does it impact
Yes,
on
please.
universal health trend?
explain. Just
Who are the
give me a minute
mothers
to
of
understand
health
exactly what is
trend?
happening, please.
That's who I like to refer
I
to as the
think
mothers and fathers of
the
clinical
video
pharmacy.
is playing now.
And they describe
Okay.
I'll
pharmaceutical
call on
care
you again.
as a
All right.
responsible provision of
Thank you,
therapy,
ma.
which is meant to achieve definite outcomes that will improve the patient's quality of life. Now, how does this apply to us as pharmacists? The application is simple. What they mean by responsible provision of healthcare, or rather drug therapy, is you're providing the patients with drugs, and you're responsible for that. By being responsible for that, I mean that you're giving the patient medication, you will evaluate the patient's response to that medication, you will follow up the patient, and you will be responsible for any outcomes that happen to that patient. So you provide that drug therapy, and your main goal is the patient is going to improve. And that improvement is supposed to improve the quality of life of the patients. What we have done traditionally as pharmacists in Kenya is that you do your mili mara tatu, you give that to the patient, and you will never see your patient again. You have no idea what they are. You have no idea who they are. You have no idea what else they're suffering from. You just service a prescription and you let them go. But now the paradigm has to change. We have to be those pharmacists that fully evaluate patients, either in an inpatient or an outpatient setting. You fully evaluate your patient. And by fully evaluating your patient, you're looking to diagnose medication-related problems and solve them. Medics usually do diagnosis of disease and prescribe. But for us, it's a different way of diagnosing. And what we are looking out for is medication-related problems. And then how are we going to then draw a pharmaceutical care plan to solve this medication? I'll give an example. When a patient walks in, what is a pharmacist supposed to do? And I always tell this to my students. I always ask them this question. When a patient walks into your facility, what do you do with them? Sometimes I get blank stares, and then I have to go and explain that a pharmaceutical consult, or what we call a pharmacotherapy worker, it involves getting the patient to sit down. Have a consultation room first of all. The traditional pharmacy window thing is gone. It is dead. Those days are done. Have a consultation room like I have one here. And then once you have that consultation room, take a patient's detailed history. And that history will include the history of their current illnesses, history of medications that they have taken before, social history, which means are there any practices or anything in their social life, for example, their lifestyle, that can affect medication adherence or they can predispose them to disease. Ask about their family. Do they have family history of, for example, drug reactions? Do they have family history of chronic illnesses? And then after you've taken that history, including the history of what is bringing them to your facility. And remember, the pharmacy is always the first point of contact for the patients. Before they find their way in hospital, these people will pass by your pharmacy. So you have to do a detailed workup of the patient, do a detailed history. Once you do a detailed history, review the patient, what we call review of systems. You have to ask the patient what they're feeling from head to toe. Sometimes when you're diagnosing, people just focus on what has brought the patient to the facility. But as a pharmacist, you need to ask, apart from what you're feeling, is there anything else? So that you have a complete picture of your patient. Physical examination will be important. You might want to find out what are the patient's blood pressures, for example. What are the patient's vitals? And in clinical pharmacy, we will go deeper into other physical examination techniques, such as inspection, auscultation, palpation, and percussion. The reason we are doing this, we are using these techniques, is not to diagnose disease, no. The reason is, if I'm giving a patient medication, let's say somebody has fluid in the lungs, yes? And then I give them furosemide. I might need to listen to the lungs to see if my furosemide is working, or if the patient's lungs are clear. I'm doing that for the purpose of clear outcomes for my medication and not for diagnosis of pulmonary disease. So physical examination is important for our patients. Now, once you have this detailed history of a patient, and then you have objective information from your physical exam, then you can correlate this information, or rather you can collate this information and then come up with a comprehensive pharmaceutical care plan. So from what you have evaluated the patient on, you have what is called a problem list. So you list all the medication-related problems that the patient may be having. And then after that, what is your plan for this patient? If a patient has been on an underdose of medication, how are you going to adjust therapy? If a patient is non-adherent to medication, how are you going to solve that issue? If a patient cannot afford their medication, how are you going to help them? And that also includes issues of economics, okay? Because a lot of people may be saying, let's give this patient an original drug. They cannot afford. That means you can't have that prescription. The patient cannot afford. You end up with a medication-related problem. The quality of life of the patient gets worse because they simply cannot access medication. So basically what I'm trying to say in all this is that as a pharmacist, you need to do a comprehensive workup of a patient and then come up with solutions to their medication-related issues. And I always tell pharmacists, there's so much that you know that you don't practice. There's so much that you do not do for patients. And if patients actually knew that you were supposed to do these things, they will hold you accountable for that. So the paradigm now, as we look at universal healthcare, is we have to move from just dispensing medication or just being providers of medication or distributors of medication, but we have to be these people who are offering patient consults. The patient should be able to say, I'm from my gynecologist, I've received my gynecology consult, and then I will go for my pharmacist consult, and then the pharmacist is the last person who is always with the patient as they leave. So we have to, I don't see how medics can do this, and we don't do this yet. We are trained at the same level. And that brings in the issues of the constant fighting with lower cadre pharmacy practitioners. That this should be the end of it, because trust me, diploma guys have been doing what they've been trained to do best, which is dispensing. But pharmacists have not been doing what they're supposed to do, which is patient consultation. And once patients are consulted, they actually, they know your value. And then pharmaceutical care is also something that cannot be practiced in a silo. It is also something that you need to practice in collaboration with the medics. So that as you diagnose your medication-related problems, these guys are diagnosing disease, and you're working together to improve the quality of life of the patient. And you have to make it clear that you're doing this for the purpose of medication, addressing medication-related problems, and they have their clear-cut rule of diagnosing disease. Then you work as a team. Once you work as a team, the patient will be able to benefit. So once you're providing these services, you have to document. The reason I'm mentioning documentation is that in clinical practice, we say if you've not documented it, then it has not been done. And we know that right now we are grappling with a situation where nobody knows what the pharmacist does. But if we do that, if we document what we're doing, then we are able to prove our work. Okay, we are able to tell these governors, hey, this is my work, this is what I'm doing for your patients, and it is improving the quality of life. So basically, I have a huge role to play. How does this then go into universal healthcare? Pharmacists have long been seen as people who just provide medication. But with universal healthcare, we are looking at the role of a pharmacist as a patient-centered practitioner, like other practitioners. And this is a practitioner who is working together with the nurse, who is working together with the medic, the lab person. We are having a healthcare team. So we have to claim our role back into the healthcare team. When you're looking at counties and sub-counties, pharmacists also have a role in public health and how medications are used outside there, because that's something that we've not really been focusing on. One of the problems I foresee with universal healthcare is actually where you have community health workers being given packages of prescription medication to walk around with. Now that is something as pharmacists that we have to put an end, because medication cannot be handled by all and sundry. It has to be handled by professionals, and for a patient to be able to access medication, it is only right that they have a comprehensive pharmaceutical consult. So as we go in and people are talking about universal healthcare, we need to put our foot down and say, hey, this is our role as pharmacists. Nobody is going to joke around with medication, because it's medicines are poisons. Nobody can actually be working on medication when they are not qualified. So those are some of the challenges that we have to get ready to address when we're looking at universal healthcare. We have to assert ourselves. We have to roll up our sleeves and work and do what we have been working. Pharmacists have been doing what they have been trained to do, dispensing, and they do it very well. The time for those wars is done. It is us guys who have not been doing what we are supposed to do. As a trainer at the university, I know that we have introduced a lot of postgraduate programs, and we are developing fellowships which should equip pharmacists in everything that I've been talking about. We have a very comprehensive clinical pharmacy program. We have a very comprehensive pharmacoepidemiology and pharmacovigilance program, and these are very important programs that bring out aspects of pharmaceutical care. We have been we've been running fellowships on renal pharmacotherapy, where we are training pharmacists to deal specifically with renal patients. We are also developing fellowships in infectious disease, in cardiovascular disease, in psychiatry, in oncology. So very soon, people should be able to come and attend those fellowships and postgraduate programs. And again, the master's programs are underway. You can apply anytime. These programs actually equip you with the basic skills, and not just basic skills, all the skills and the knowledge you need to be a pharmaceutical care expert. So if you're feeling a bit rusty and not so confident, please welcome to the University of Nairobi. We shall take you through and make you a good pharmacy consultant, because right now we need to be doing pharmacy consults and nothing else. We have to stop fighting with pharmtechs. And also, when you're doing a pharmacy consults, it's a very easy way to deal with quacks. You see, you'll not be fighting with a quack who cannot be able to do a pharmacotherapy workup for a patient. So we have to reclaim our space back into society. We have to look very critically at this universal healthcare thing and make sure that our patients are not being given inappropriate medication by unqualified people. So, thank you for this opportunity. I'm looking forward to the conference, where I think I'll be able to contribute a lot more on the subject. Thank you.
Thank you. Thank you for that short clip. It's talking about pharmacists as consultants. Thank you very much. We now proceed to the question and answer section. And I remember Dr. Pharmacist Aderonke was asking a question just before the video clip came on. Pharmacist Aderonke, are you still online?
Yes, please.
Okay, please, ma, proceed with your
All right.
question.
Thank you very much. Dr. Bono, thank you so much for the presentation. It's an eye opener. And this is my contribution. Looking at an hospital setting, most times the pharmacy department is usually short-staffed. So most times the focus is on dispensing and reducing the crowd, leaving little or no time for professional services follow-up of patients, especially admitted patients. It has almost become a routine. Just dispense the drugs and let it go. However, it is still not an excuse because I'm almost coming to the conclusion that it is a deliberate attempt to shut down the pharmacy profession. That is why enough pharmacists is never employed into the services, into the hospital services. Most times when they are employing, the ratio of doctors to nurses to pharmacists is so wide. By and large, this is not an excuse. I think that even if it's going to be a ward at a time, a health condition at a time, let us start something. Let us start getting the statistics. How many of us can say this is the number of diabetic patients that comes into the clinic in a week, in a month, in a quarter, in a year, or hypertensive patients? We've got it all mopped up because there's absolutely no time to even breathe in, talk less of paying extra attention to a patient. But I think despite the low strength in number, we can start up something. Maybe pediatric ward. Let's start getting all these benchmark indicators. Maybe surgical ward, maybe cardiovascular patient, maybe diabetic patient. Maybe let's conquer a ward at a time, a condition at a time. Let us be grounded in one area, conquer in one area, make our relevance known in one area. Needless to say, we will be invited into the other areas. So a step at a time, despite not having enough hands, if we can start off properly and strongly, one at a time. In another 2 years, less than 36 months maximum, will have made solid impact. And this is just an opportunity calling on all pharmacies. I know it can be tough, especially in federal hospitals, it can be tough. Absolutely no time to do anything except traditional dispensing. But I just want to encourage us all, no matter how small, in our little corner, let's start shining the light. Thank you so much, Mrs. Obono. And I agree totally with Dr. Jordan. Let's have a benchmark that is applicable to all institutions. So that when we are comparing apples to apples and not apples to orange, as our speaker has said, let's have a benchmark, let's have a guide, and let's give ourselves timelines. Then we can move on and start this. Enough of talk. I think it is time to walk the talk. Thank you very much.
Thank you. This is a suggestion. Thank you, Dr. Pharmacist Aderonke.
Thank you, Ronke.
Thank you. Dr. Margaret, any response before I move?
Thank you.
I think it was basically a comment.
Yes.
Yeah.
Okay. So I quickly move to Dr. D.O. Baba. Please, sir, unmute yourself and proceed with your question. 2 minutes.
Hello, good
Thank
evening.
you. Good evening, sir.
Good evening, everyone.
You're welcome, sir.
Okay, thank you, Dr. Margaret, for that presentation. It's actually an expose of what we need to do as clinicians either in the public hospital or private or in the community practice. I can classify those indicators into 3: structured indicators, process indicators, and outcome indicators, which are things that actually will help the system to be strengthened as we go along. See, the issue is, I was going to talk on the issue of the number, as my last colleague talked about. The number actually is not an issue. If we feel the number is an issue, we could start from benchmarking even our community practice, so that if that is the area that we feel being appreciated, because the bulk of the work that will be noticed by the public easily is the community practice. If we could start from that angle, it will go a long way to even showcasing what we know how to do. But the truth of the matter is that we have to start from somewhere. And actually, this is an eye-opener to even SIPAN to come out with an idea, just like Dr. Jordan suggested. We should have a national tool that we could leverage on to say that, okay, what is being practiced in Kano is the same that is being practiced in Lagos and across board like that. That is how systems develop over time. And it's not something that will come overnight and we don't have it today and then get it. We must compare our services if we really want to make headway. And as the presenter said, we actually have this if we have this as a working document, then we can chart a way forward to kind of improve our services and make ourselves visible to the health community. Because like that video suggested, the whole idea is tilted towards universal health coverage. And for that UCH to be, or universal health coverage to be achieved, then pharmacists have to be visible. Because if you look at the percentage of outpatients, it's about 90% to the primary settings. That is, whether you look at it vis-a-vis the community practice or primary healthcare centers, it's only 10% of patients that go to our tertiary and secondary and tertiary health institutions. But 90% source for their care or seek for their care or access care at the primary level. So the focus now, if we really want to go on with this, our community aspect has to be really engaged so that by the time they start showcasing this approach at that level, the government will have no option rather than to kind of toe their line and then see pharmacists as, or clinical pharmacists as healthcare practitioners. So in all, it's a good thing that we're discussing this and we're having this presentation so that all of us will be on the spot to kind of discuss what will bring about the development of this profession in the country. So thank you again for Lagos for that wonderful presentation tonight. Thank you.
Thank you. Thank you, Dr. Baba. We appreciate your suggestions and your comments. I'll call on Dr. Ejiro. Your hand is raised. Please unmute yourself and proceed. Thank you.
Thank you very much for this opportunity. I want to thank Dr. Bono for this wonderful presentation. Unfortunately, this presentation was not available as at when the hospital review, hospital accreditation tool by council was reviewed in Nasarawa. Madam was there when the tool was reviewed, but this wonderful detailed benchmark tool was not available for us then. So I want to say a big thank you to her for making this come up now and the discourse is on. And like was earlier mentioned, it would be nice to have a national tool which should be channeled through the Pharmacists Council. However, irrespective of the tool, something that came up by the review committee chairperson, Professor Kunle then, was that when inspection team comes and these benchmarks are not met, council seem not to weigh the big stick, as it were, because of our colleagues, the fear of our colleagues losing their job. But the truth of the matter is, we must be hard on the system for certain changes to take place. And the question of our numbers, I quite disagree with the notion that there is no time and we are few. The truth of the matter is, in the health system, no matter the number of patients that are present, the nurses will not say because you have only one nurse, the nurse will not take the vital signs. A physician will not say because there are so many patients, he will just rush through all the patients. He will still take his time. But in pharmacy, we seem to be in a hurry to just dish out the drugs, and we create the notion within the system that with only 2 pharmacists, you can actually handle 2,000 patients in a day. While doing my internship, I insisted on following through on prescription assessment, patient counseling, all of that, even when my senior colleagues were saying, just give this one out. Now we need to practice these benchmarks. Let the system see that there are so much patients and the pharmacist is doing what he or she is supposed to do. Then they will see the need for more hands. You cannot make case for more hands. But where the few persons available seem to take care of the 5,000 patients, the system will not see the need for more hands. When you tell them you need pharmacists, when they are employing 100 doctors, 200 nurses, they will just employ 5 or 6 pharmacists because they know the few hands will be able to absorb the crowd, as it were. So I think it's high time that this is coming up now and there's need for this discourse. Let us do practice clinical pharmacy the way we should, no matter the numbers we have. The system will see that there is a need for more pharmacists. When they see the patients crowded out there for outpatients and we are not in a rush, we will not be struggling with technicians then, because then we will see that there is need for pharmacists and there are needs for technicians. That's my contribution.
Hey, Dr. Ejiro. Before I call on the next hand raised, I want to give Dr. Ejiro 10 bossas for this point. I'm solidly behind him. The inspection team should learn to wield the big stick when things are not done properly. I mean, don't be scared. They shouldn't be biased. They should be able to make their point known there and then, even if it entails closing up for some days for the right thing to be done. I don't mind. The important thing is that the right thing should be done. These benchmarking tools should be used and applied. So I quickly call on Dr. Dola, and I would please ask you to use just 2 minutes. You can unmute yourself and make your suggestion or ask your question. Thank you. Dola, I hope I pronounced it well. Unmute.
Good. Okay. Can you
Yeah,
hear me now?
very clearly. Please
Right,
proceed.
okay. So my name is Dolaido. My background, I'll just quickly tell you, is cardiac physiology. I'm not a pharmacist. We are not even allowed to even give patients oxygen. And one of the things I joined one of these meetings, I think 2 weeks ago, and one of the things I've learned from this is that documentation. How how does when you in clinic uh, give a patient or prescribe a drug or tell a consultant to say no, that drug might have contraindication. How do you document that? Because what I work in the NHS, by the way. But yeah, it's just to ask, how is the documentation done? That's my question, pretty much. And also, maybe later, if I'm allowed to, I would like to sort of show what we are doing here, or do a presentation on what we're doing here that is working for us, or that seems to be working for us anyway. But yeah, that's the question is, how do you document? and request is, if you will allow me to, I can present what I think would be a solution. Well, could be a solution. Thank you.
Thank you very much. I'm looking at the time, and I wouldn't know if we have so much time to continue the questions, but the last question, Pharmacist Williams in Kemjika, please unmute and ask your question briefly or suggestion.
Good evening, everyone. Pharmacist Nkemchika Williams. I want to thank the presenter for such a wonderful presentation. In several platforms, always suggested that the implementation of pharmaceutical care and creation of benchmark in pharmaceutical care would be easier if we have a documented proof of our interventions. Johnson and Buchman did a lot of work in America before the implementation of pharmaceutical care. They did a work like drug-related mortality and morbidity and their economic impact. And they were able to show some data. Even anybody that reads such result from such presentation will quickly implement anything they say about pharmaceutical care. Like one of the things they discovered was that 1.3 million, that drug-related problem caused about 1.3 million hospitalization and about 63,000 deaths. And if such, if we have such data in Nigeria, I don't think we will find it difficult implementing pharmaceutical care. I was doing my residency in one of the hospitals in South, and one of the clinical pharmacists wanted to take a collation of all the prescriptions that were not properly done, and wanted to put it together and let us use it and make a statement. But we discovered that even fellow pharmacists were kicking against it. And I want to say this to us: if all of us we go back in our various practice settings and we go and implement documentation, I think that's one of the important part in pharmaceutical care. If we can have proper documentation, as little as you can document, and we collect it together, we will form a benchmarking tool that will be specific to us. That's my little contribution to tonight's presentation. Thank you.
Thank you very much, Williams. Please, I would, at this point, I will call on Dr. Obono. Please, ma. Dola talked about documentation, and Williams is also talking about documentation. Before I call on my chairman, Dr. Madu, I would love Dr. Obono to please give us her last words addressing the suggestions raised. Thank you very much, ma'am.
Thank you very much, my moderator. Yes, like everybody has said, we know the guiding principle. If you don't document, then you didn't do it. And most times, you can even go online to get formats of documentation. There is something I came across online, pharmaceutical care documentation form. About 3 versions of it online, which we printed in my institution that we are using. And you could always come up with drafts for so many other things you want to document. And if these things are made filler friendly, you don't need too much time. Like some of us are talking about, we have few pharmacists, we have so many patients. Filler friendly, tick, 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 and later you can sit down and add in the details. We will have these documents there, and we will be able to have data and have these things to work with. It is important to document whatever we are doing, and nobody will do it for us but us ourselves. And if we don't document, we will not be able to prove our value, what we are adding to the healthcare system, or what we are doing. Then we will continue to be looked at as those people that sell drugs. I keep arguing that thing. Don't tell me I sell drugs. I'm not here to sell drugs. I'm dispensing and I'm offering pharmaceutical care services. So I think it is important to document, and that is what I would just say. It is vital.
All right. Thank you so much, ma'am. I now call on my chairman in the person of Dr. Madu. Sir, you have the floor.
All right. Good evening, everyone.
Good evening, sir.
I believe you can hear me, please.
Loud and clearly, sir.
Yes.
All right. God bless all of you. It has been a wonderful time tonight. And as I said, I believe we have all gained a lot. I want to thank Dr. Obono for this knowledge impartation. Definitely, everyone here this night has gained something that they are taking away. I also want to thank Dr. Arino Lajoda, the Lagos Japan coordinator. Lagos is watching. Congratulations. Let me use this opportunity to say, yes, a lot of people have said different things this night. We are also planning that very soon, by God's grace, using the strength that He will give us, Sipa may have an interactive session with HODs in Nigeria. I think we'll all be talking at that level and we'll be telling them what we want. I believe that will go a long way because when we are doing these things at different parts of the country, before you know it, we will be making impact. And it is a movement that by God's grace, it has started and it's a moving train. No one can stop it. So I want to thank Dr. Obono. I saw something on her citation. I think from National Orthopedic Hospital in Bobi also. I believe she may be one of the HODs or past HODs. So she may be with us then too. But like Dr. G.O. Baba said, documentation, everybody is saying documentation this night. Yes. What do we document? How do we document? And this lecture this night tells us about comparisons, that's benchmarking.
Yeah.
Yes, that will help us. What the pharmacists in Sokoto are doing should be the same with what pharmacists in Port Harcourt or in Lagos are doing. Not everybody doing their own thing. Thank God for Sipan. I believe as clinical pharmacists, this association is bringing us together. There is one thing I've always thanked God for. I know that those people in medicine, that's enemy, they seem to know better than us before now. The reason is because they are always challenged. They are always learning. Even if you don't want to learn, their system makes it for you to learn. The moment you leave the hospital or you leave the world, you go and learn something because you are challenged. But in pharmacy, they are not doing that. But with the kind of thing that is happening in Japan now, we are learning. We all discover that we are gaining one thing and the other, and we can stand anywhere, raise our head and see. It's only a matter of short time before we know it, we'll be doing better. And like Dr. Obono said, when we are not there, our absence will be felt. So I want to thank everyone this night. God bless all of you. The moderator did not tell me that it's going to be a closing remark, but I believe what I'm saying will serve as closing remark. May God continue to bless the farm. May God bless pharmacy profession in Nigeria. Thank you very much. And please let me chip in this. We still need more hands in Japan. I keep on saying that the harvest is plenty, but the laborers are few. And I want to plead with Lagos Japan if she can donate more members that are willing to serve at national level. Like some of these things, we have been saying, yes, we want to design a template that can be used across all the hospitals. I did something at a time. We started rapid response group after our visit to National Assembly on MDCM bill. I thought that we should use that group to create this documentation form. We know that can happen habit, but we want to create something that maybe compared to that will be uniform across the country. I brought in certain things to that group, but everybody seems so busy. So at the end of the day, we didn't do much. Please, if you have more passionate members in your system, because it's not all about saying CPAN is supposed to do this, CPAN is supposed to do this. If you ask how many CPAN ESCO members are in this meeting this night, I'm sure we are not more than 4. But CPAN has more up to 12 members in our executive. It's the same across the publicity committee, the education committee. Only few people are doing this work. And if we continue like this, people will get exhausted. But I feel that if we can have more members, that will help to always relieve those who are working and will have more time to rest. Sorry for taking your time in talking for too long. God bless you. Thank you so much, the moderator. Thank you so much, Dr. Bello, who has always been there for us. Only God will reward you for CPAN. Amen.
Amen. Amen. Amen. This is a serious prayer by our chairman. Thank you so much, sir. Thank you very much.
Has given a
Um,
closing remark and prayers.
yes, he has given a closing remark at the prayers, but we still need a
Yes.
closing prayer. But before I call on Dr. Motehat Olulawal, our secretary, national secretary to PAN, I want us to know that even if we do not go home with anything tonight, if you do not add value wherever you are, your absence will not be felt. So let us aim to always add value. I learned that from one of her slides. Let us aim to always add value wherever we find ourselves. That way, when we are absent, we will be missed. Thank you very much again. I now call on Dr. Motehat Olulawal, the CPAN National Secretary, to give us a closing prayer.
Changes afoot at half-time here in Bologna.
You there?
No, she's not on the call.
Dr. Rinola Joda, please, can you give us a closing prayer, ma?
Okay, ma. Good evening, everybody.
Good evening.
Providence has fallen on me to give the closing prayer. And I will use that opportunity before I pray to thank Dr. Obono for a very well presented topic to CPAN representing Lagos very well. You know, they say Lagos for show, but me, I have since been adding Lagos for show and for action. And
yes,
we proved it again. And we proved it again.
God,
We thank God.
Right.
We thank God for that. And Chairman, I heard your cry, and we will see how we can donate members to the work that is ongoing. God will help all of us. As Chairman said, is everywhere in pharmacy. In Public Health Pharmacists Association, there are 4 people doing the work, 5 people doing the work. In West African Postgraduate College, there are 3 pharmacists, 7 pharmacists. You know, everywhere in pharmacy, you have a few people doing the work, carrying all the weight. But eventually, I believe that is where every growing organization, every growth organization, every thriving organization, that is how they start. Not everybody catches the vision at the same time, but eventually, with the persistence of those seed few, others will begin to see the light, and then others will begin to contribute their time, and then it will enter a free flow, a momentum will be gathered, and everything will be flowing well. So I believe that by God's grace, we will soon enter into that phase where sufficient momentum has been gathered, and everybody is available and ready to do their own bit. Let's pray. Our Father and our God, we thank you. We glorify your name, we bless you because you are good, because you are faithful, because you are kind. We thank you for protection. We thank you for your favor. We thank you for your mercies. We do not take you for granted, our Father. Lord, accept our thanks in Jesus' name. We thank you, Lord, for this presentation, and we thank you for SIPAN for this idea of a weekly presentation. Pray that you continue to preserve each of us to be able to contribute our quota even into this association, this growing association that you have ordained to the glory of your name. Lord, we thank you for all of us that are on this call, those that have been and have fallen out, those that are just joining, and those that will say, oh, I missed it, I forgot, oh, what happened? We ask that you continue to bless us with your manifold blessings in the name of Jesus. Thank you because you will keep us onto another week, onto another time. And Lord, you will continue to enable us even to do that work that we have indicated interest in doing. You will continue to strengthen us to put in our best in those places that we have volunteered. And you will continue to grace us with health and strength and courage and wisdom to perform our roles creditably and in a way that will give honor and praise to your name. All this I ask in Jesus' mighty name, I prayed. Amen.
Amen. Thanks everyone. Good night, everyone.
Amen.
Good night.
Good night. Good night, everyone. For this successful.
Before we leave, can I ask who is the best person to speak to if I wanted to do a presentation?
I guess that would be the chairman of the education committee.
Dr. Madu? Or
Dr. Chimi.
Dr. Chinwe?
It should be the chairman of the education committee.
Yes, Dr. Chimi, please.
There's a schedule for the presentation.
I'll send my email now, and it's just to do a presentation and see what we're doing here and share it if it's any good or any value. And yeah.
Yeah.
From which state now? From which state?
Well, I live in Leeds. I'm from I'm from Ondo State, but I live in Leeds, England. So I'm talking from Leeds, England.
And you say you work with the NHIS.
I work on the NHIS.
Yeah. So I think it's Dr.
a month or date for presentation now.
Chairman is coming from the UK.
Yeah, it's just to share what we're doing now and how we can then sort of discuss how that can work in Nigeria.
Chairman, you should talk with you or with Dr. Timipre.
Yes, he will talk with me or Timipre. Then please remember to get the slides of this presentation for us, please.
Oh yeah, I'll send it to you. As soon as we've sent it, yeah. 1 second, let me just sorry.
I hope we can still make our contributions and ask questions offline.
Oh yeah, absolutely. Yes. Yeah, absolutely. It's just to sort of see if it works in Nigeria because not be everything you work
the questions are not to you. You will talk with you will talk to Dr. Madu or Dr. Timipre offline.
Okay.
But questions associated with today's presentation can still be taken on the SIPAN.
You can on the Telegram platform. Telegram
platform.
Okay.
On
the Telegram platform. Okay.
Because I wanted to make contribution and ask questions, but because there was no time, I couldn't.
Okay.
Share it on the group.
All right.
I'll send my details privately then.
Okay. All right.
Good night. Good night, everyone.
Good night, everyone.
Good night, everyone. Good night.
Good night.
Have a